the good thing in life is that we have a lot of choices, and this applies also to the left main stem. We could either go for intracoronary imaging or use physiology. And the question is left main a surgical disease? We have surgeons here. And based on the big studies, the big randomized studies, it seems that it's not just for the surgeons. They might do it slightly better, but we can do it as good as them. So we have comparable long-term risk of death results. However, we might get more procedural MIs and have repeat revascularization compared to CABG. Anyhow, this means that we need to have options once we see the left main stem disease. And the problem is that we should or we should not trust our eyes. And one of the most important studies in the field came from one guy inside here, Dr. Hamilos, who performed this initial study that shows that we cannot really trust what we are seeing. And also because I'm a big fan of the Polar Express, seeing is believing. However, sometimes most real things in the world are the things we cannot see. So although the left main stem might have some appearance of important disease, we need to be certain that this is causing some kind of ischemia. And for this reason, we have a lot of imaging modalities. We mentioned some of them, CCCTA, the coronary angiography, IVUS primarily, and to less extent OCT based on some of the limitations of the method. When we are talking about intracoronary physiology, this needs to be further explained and show that it's not identical either using IFR or FFR. And there is a quite big discordance, especially when you use it to identify lesions on the LAD, left main disease and LAD, and also when you use it to identify lesions on the left main and the circumflex. And this goes up to 1/3 of the cases. And also, there is quite a big discordance between IFR, FFR, with a cutoff of 6 for the MLA in left main, and this applies to more than 30% of the cases. That means that we get different information, or we get not exactly the same information from imaging and from the coronary physiology. However, we get information, and this is seen by the fact that when you use IFR, FFR, and IVUS, we can reclassify more than 40% of angiographic intermediate left main lesions, either to significant or non-significant and vice versa. And this could lead to the change in treatment plan. And what we can say based on the studies we have so far, when we have a concordant IFR and FFR positive left main lesions, yes, you should treat it. If you have a concordant negative, probably you should not treat it. However, there is a slight chance that you might get an event. And when you have a discordance between IFR and FFR, then you don't know. We don't know. And usually in these cases, we need to reassess the patient, and often we need to have a second modality, and probably this will be IVUS. There was initial some studies showing that there might be safety in using IFR to assess the severity of left main stem disease. However, recent data show that FFR is far superior to the non-hyperemic indexes, and this was done with a very nice study, recent study that showed that when you have when you try to detect functionally significant left main stem disease, this is not very helpful when you have non-hyperemic indices. So you get a lot of false negative results with the non-hyperemic indices, and we need to apply this modality with extreme caution. So what to use in clinical practice, except our own judgment? These are primarily what we use, the cutoff points in the cath lab, 6.0, then we can be certain that there's going to be a good result by deferring PCI or CABG. Below 4.5, we need to revascularize, and I would strongly consider physiological assessment between 4.5 and 6. Thank you very much.
Dr. Terentes, may I ask you, of course, you delineated the whole algorithm, how to proceed in this case, but specifically for this king left main, are there any dedicated studies? Because we hear that imaging also may have some limitations, OCT also the left main were so good. So for this, because this is a special picture that we occasionally get.
So practically, many of the studies that have been done have also ostial lesions, as this one. And first of all, definitely the IVUS...
No, I'm not talking about ostial lesions, about this morphology.
You mean the kinking in
Exactly.
the aorta?
Exactly.
To my knowledge, I don't remember having especially this, this morphology studied. But all the studies on the left main, and especially for this left main, you would use an IVUS due to the large size, have investigated these small discrepancies in the morphology, and they can derive quite helpful results, even due to the kinking. So.
Okay. Dr. Kanakakis has a comment.
Short question. In the last slide, you show us that in the gray zone between 4.2 to 6, you can use physiology. What the physiology will offer and how you will use it?
So, first of all, we need to understand that all these cutoffs have been based on studies that we have from non-invasive function tests. So, practically, if you have two modalities that are positive, then you might be more certain that the patient will benefit from revascularization. For example, if you have a left main that is below 6 and also an FFR mainly positive, then you can feel safe that this left main disease is severe and you can go ahead with the revascularization. And this has been shown in studies that these patients benefit from revascularization. When there is a discrepancy, the results are not that convincing.
The discrepancy is the problem. If both tests are positive, so the answer is simple. But if there is a discrepancy, here is a problem.
So practically, it's not a negative result, 4.5 to 6. It's an intermediate zone. And if the physiology shows that this is significant, then you have two modalities that are confirming that there is a severe disease.
Check.
Yeah, exactly.
Dr.
You need a
Aznaouridis.
confirmation.
What about non-invasive CFR, coronary flow reserve in this case? If it is good?
So practically there are not that many data on CFR and left main disease, but definitely you can use it. If there is any disease on the arterial tree, then you will get a CFR that is abnormal. I would not use it, to be honest, because I don't have any data on the prognostic role of using CFR to assess if we need to go for revascularization. However, I would use FFR instead of CFR.
However, I think you showed a recent study that non-hyperemic estimation is inferior.
That's why I said FFR. I would use FFR instead.
Simone, would you use an angio-derived FFR for left main?
No.
No. Okay. So this is the answer to Dr. Abramovich.
Okay. Then.
Should we see what happened? Kostas, what you did?
Exactly what happened.